severe immunodépression for HIV.
For inviting me to present the DATURA trial. And I know everyone is tired, and I will try to do my best to get your attention. That's the disadvantage of being one of the last presenters. So today I will be talking about the DATURA trial, and I am a principal investigator in Mozambique. I will be talking about the concept of DATURA and some baseline characteristics of the patients that were included in the trial. 20 or 25% of HIV-infected adults, they arrive very late for care, and most of them already have their CD4 below 100. TB occurs frequently within this group, and they have very high risk of mortality, especially because they already have very much advanced symptoms. And in this group, around 30% of patients would die even if they have a recommended regimen, TB treatment delivered correctly to them. There are studies that have shown that there are significant reduction of some of the TB drugs plasma concentrations in the patients who are TB HIV co-infected, and especially on those which are severely immunocompromised. And that's why the hypothesis of the DATURA trial is to show that if we increase the dose of two major TB drugs, rifampicin and isoniazid, and adding a corticosteroid, systematic corticosteroid, we will be able to decrease the mortality in these severe immunocompromised HIV-infected adults and adolescents that are hospitalized in comparison with the current treatment for TB. So the objective of the trial is to estimate the impact of this intensified initial phase of TB treatment in the mortality at 48 weeks in this group of adolescents and adults that are hospitalized with the TB and having CD4 below 100 copies per ml. The trial is a phase 3 multi-center trials that is being conducted in 6 countries. It's an open-label randomized trial and has 2 arms, as I mentioned. One is the intervention arm, where we will increasing the doses of the 2 TB treatments. The rifampicin will be given in a dose of 35 plus minus 5 mg per kilo daily, and isoniazid will be increased to 10 plus 2 mg by kilo daily. And we will also add in this group corticosteroid treatment for 6 weeks, and others will remain almost the same. And the standard arm will be using the current WHO regimen with the standard dose that is available. In both arms, the patients after the initial phase will continue with the maintenance phase with the same as standard treatment. For those who were not in treatment, the HIV treatment was initiated after 2 weeks, and the dolutegravir was given as a rifampicin, or dolutegravir was given as a double dose. In terms of statistical analysis, the primary endpoint was the time of death from any cause that occurred within 48 weeks after the randomization. The sample size was calculated to show a decrease of mortality within these 2 groups at least by 34%, considering that the control arm would have 20% of mortality and then reducing to 13% in the interventional group. With a power of 90% and alpha of 5%, we will need to randomize 1,330 patients in the trial. In terms of inclusion criteria, we included patients from 15 years, that's why we say adolescents and adults, who had confirmed HIV infection that needs to be documented prior to the entry, a CD4 that has to be below 100, equal or 100, and should be hospitalized patient with a newly diagnosed TB that can be defined by any of these three. Any positive expert result could be in any sample, sputum, urine, pus, or any other that was available, or could also be included with a TB-LAMP positive result or an abnormal X-ray compatible with TB, active TB, if the other two were not positive. We have a list of non-inclusion criteria. One of the things is that we should not include patients who already started the TB treatment for more than 7 days or had a history of treatment for more than 6 months. We also exclude patients who had neurological symptoms, and also TB meningitis was excluded, or patients who had suspected TB pericarditis, and of course any patient who had confirmed resistant for TB treatment. HIV-2 co-infection for countries where HIV-2 is prevalent, and also excluding patients who were on protease inhibitor treatment for HIV. And also we needed to exclude those patients who required corticosteroid per their condition, because if they were randomized to a control arm, they were not able to be on those corticosteroids. Also, we need to exclude patients who had impaired hepatic or renal functions in order to ensure their safety due to increased dosage of the treatment that we were providing to them, and also excluding pregnancy and breastfeeding. The first inclusion of the trial occurred in 2022, April, and the trial has already stopped the recruitment on 13 December last year. Still, patients are being followed up and until December 2025, and final and data management is expected by June 2026. In terms of study sites, as I mentioned, we have, this is a multi-center trial with 6 countries being involved in this study: Cambodia, Cameroon, Guinea, Uganda, Zambia, and last, Mozambique. I will say last because we were the last one who were invited to participate in this study. In fact, it was in end of 2023 that we were involved in the DATURA trial. I will talk a little bit of Mozambique, the institution that I belong. Instituto Nacional da Saúde is a public health institution who aims to get evidence by research to resolve issues of public importance in Mozambique. And TB is one of the highest priority for us. CISPOC is a center that is located in Maputo City, and it is focused on implementing clinical trials. We have lots of sponsors who sponsors or fund our studies, and I just mentioned here some of the ANRS funded projects. Carinemo, which actually was my first study that I worked when I just graduated. And then we had Reply Timpani and DATURA actually. So it's a long way with ANRS right now. Now moving to the characteristics of the patients that were included, we stopped the inclusion with 907 patients included in the trial. Also, I need to mention that the randomization was stratified by the CD4 being below or above 50, and then you can see that we have a little bit more patients that had less than 50 copies of CD4. In terms of characteristics, 44% were female, with a median age of 37, and I want to raise here that the median BMI was 17.6, and if you stratify below, you can see that 30% of the patients had a BMI below 16, showing that they were actually extremely sick, hospitalized patients. In terms of median Karnofsky score, it was 60. You can also see that the median hemoglobin was actually also low, 9. You have some countries that were a little bit lower. And a median CD4 count, as I mentioned previously, was 43. So we are seeing a very immunocompromised patients here. The TB test that allowed inclusion, here we can see the 71% of the patients that were included in the trial was based on an expert positive result. 25% was based on TB-LAM positive, and only 4% was based on a clinical criteria of X-ray, knowing that all the other two were actually negative. So showing that we really included based on a positive expert. I already mentioned that we already stopped the recruitment. The patients are being followed up, and the results will be expected by mid-2026. So I would like to thank all the trial participants and their relative, the sponsors, the investigator and clinical trials, and Didier especially for allowing me to present this, trial. And thank you very much for your attention. Hope I'm on time.
Thank you very much, Bindiya, and thank you because we were late and now we are not anymore. So thank you so much. We have questions. Yes.
I have two questions. The first one is perhaps I misunderstood, but did I see that the patients were put treatment? The ARV were efavirenz. They were also taking rifampicin. Because of the interactions, I'm asking the question, obviously. And what is planned in the study for the families of the patients with TB, children, etc., living in the same household?
Okay. Should I respond? Yes. No? Okay, so Didier, will you help me? But at least in Mozambique, almost, I would say, 100% of our patients are not doing, they are doing already dolutegravir. So I don't know if in other countries is like that. So I'm not sure that anyone is taking efavirenz. Yeah, I saw also that in maybe when the project was designed, still patients were having efavirenz. And your second question was about the relatives and the family. As per protocol, we don't have any intervention for them, but as a program, any patient who is detected with TB, we counsel the family to get a screening, and we invite them to the screening in the near hospital, and it's a common standard practice for them. Yeah.
Thanks for this presentation. I saw the CD4 are very low. Did you have any IRS despite corticotherapy?
So, yeah, so I would just say about Mozambique in terms of cases, if we had IRS or not, but we have one case of IRIS, but that was much, much earlier than, it was just after they started, but it was more related to their already pre-condition. So I don't know, Didier, if you want to answer?
As you can imagine, I will not answer because we will just present the baseline characteristic of the patient and we continue to follow. But I will just say to you that we have less IRIS than we expected. And I cannot explain why, because in previous studies, not only in Camellia in Cambodia, the same patient, we had 25% of IRIS. But in this trial, we have less.
Yeah.
Thank you very much. Did you mention the number of patients that were not included because of evidence of resistance?
I don't have the number here, but we, not that much, but we have few cases in Mozambique, at least, that were not included due to resistance. But they are very few, especially because I want to explain a little bit. The study in Mozambique is being conducted in our, what we call referral TB hospital, where all the cases from all over the country, or at least from the south of the country, are referred to. So we had cases that we couldn't include because they have resistance. Because next to our clinic, we have the, MDR, XDR clinic. So they are referred to that, that clinic. Yeah.
Thank you so much. Thank you.